Welcome back to our image analysis. We're going to start with the medial oblique practice analysis. The first thing you want to look at is, do we have all our anatomic structures, which we do. We also want to look at our joint to determine if it's open, which I will say that I feel as though that the medial aspect of this joint here is slightly closed, so there may be some central ray angulation issue, even though it's not stated here. Also, you want to determine, is this medial oblique fit criteria? And the first thing you want to look at is whether that fibula-tibia relationship is appropriate. And at this point, the tibia is superposing a great portion of the fibular head. Therefore, this knee projection is insufficiently rotated. We need to increase the degree of rotation until those epicondyles are 45 degrees with the IR, freeing that fibular head of superimposition. So now let's take a look at insufficient external rotation, or for the lateral oblique. When the epicondyles are not 45 degrees with the IR, the fibular head will not be completely superimposed by that anterior portion of the tibia, as demonstrated here in this projection. That is when you have insufficient rotation. You will need to increase the rotation so that the epicondyles are 45 degrees externally rotated to get a true lateral oblique projection. In excessive lateral oblique rotation, you're going to, again, look for that fibular head and determine its position in relationship to the tibia. As you can see, the fibular head here is not aligned with that anterior edge of the tibia, but it's seen posterior to its placement it should be. Therefore, you are in excessive internal rotation. You're going to need to decrease that rotation down to 45 degrees to get those epicondyles and that fibular head right where we need it to be to obtain the image. So let's take a look at this practice analysis here for this lateral oblique. We got a few things wrong here. First, like I always say, you want to look at whether we have all our anatomic structures, and we do. Second, we want to determine whether this joint space is open. And the lateral joint space is open, but the medial is closed. So we have some central ray angulation problems. With looking at this fibula, it looks like it is elongated. So this tells me that the central ray was angled too caudally. Therefore, since it grew and it became elongated, we need to angle with the direction the fibular head went in order to place it appropriately. Second, we are conducting a lateral oblique projection. The fibula head is not completely superimposed by the anterior edge of that tibia, so we're insufficiently rotated. We need to increase that leg rotation to 45 degrees for those epicondyles to be at that 45-degree angle with the IR to place this projection, or the anatomy in the projection, in the positioning that it needs to be in. Let's move on to our lateral knee projection. Image analysis guidelines for the lateral knee projection state that the patella should be situated proximal to the patellar surface of the femur. The patellofemoral joint should be demonstrated as open. The fibular head is a 1/2 inch distal to the tibial plateau. The knee joint space should be open. The anterior and posterior margins of the medial and lateral femoral condyles are aligned and superimposed. The tibia superimposes 1/2 of the fibular head. The knee joint is at the center of the exposure field. 1/4 of the distal femur and proximal lower leg and the surrounding knee soft tissue are all included within the exposure field. The first step to take when evaluating a poorly positioned lateral knee is to distinguish the lateral condyle from the medial condyle. The most reliable method here is to identify the medial condyle by locating the adductor tubercle on the medial condyle, as you can see here. It is located posteriorly on that medial aspect of the femur, just superior to the medial condyle. The size and shape of it varies and isn't identical on every patient, but it definitely, the margin on that side is definitely different from the lateral condyle. Once you identify that adductor tubercle, the medial condyle is identified. Another difference between the medial and lateral condyles are their distal articulating surfaces. The distal margin of the medial condyle is more convex, and the distal margin of the lateral condyle is more flat. We know for a lateral knee projection, we must angle cephalically 5 to 7 degrees to superimpose those distal margins of the condyles. But when no angle is used, the resulting projection demonstrates the distal margin of the medial condyle distal to the distal margin of the lateral condyle. AKA they're not superimposed. A narrowed or closed knee joint will be demonstrated in less than 1/2 inch of the distance between the fibular head and tibial plateau. Now, when that central ray angulation is excessive, more than that 5 to 7 degrees, or at 7 degrees, and we may need to bring it down to 5, depending on the individual's anatomic structures. The distal margin of that medial condyle is projected above that lateral condyle. Narrowing, or you'll see a closed joint space, and you'll also see more than 1/2 inch of the distance is demonstrated between the fibular head and the tibial plateau. When looking at rotation, we're going to recall looking for that adductor tubercle. When you identify where that adductor tubercle, you are identifying the medial condyle. When the medial condyle is demonstrated posterior to the lateral condyle, that means that there is some internal, or we're excessively internally rotated. We may have to increase external rotation to get a true lateral projection. In external knee rotation, again, we're going to look for that adductor tubercle. And as you can see, the adductor tubercle is identified, and that is the medial condyle here, which sits anterior to that lateral one. So we're in excessive external rotation, where we need to bring that knee back so that the condyles are superimposed. So let's take a look at this practice analysis. First, we know they're doing a lateral projection. Do we have all our anatomic structures? Yes. Second, we need to determine some rotation. We need to look at our anterior and posterior margins of our condyles. Are they superimposed? This is a patient with a knee replacement, so they are a little bit more difficult, but you can see that the prosthesis posteriorly is not superimposed here. So we have some rotation. The easiest way to determine rotation when you cannot see the adductor tubercle is to look at that tib-fib relationship. That fibular head is starting to become free of superimposition, so we are externally rotated excessively. We need to bring that knee back so that, or internally rotate the leg until those femoral epicondyles are perpendicular with the IR. For this next lateral knee projection, we want to look and determine whether or not we have all our anatomic structures, which we do. Second, we need to determine if there's rotation. And when you look at the anterior and posterior surfaces of these of the condyles, they are not superimposed. We don't have an open joint space. We're not meeting criteria. Also, you can see there's an angulation problem because the medial condyle is sitting lower than the lateral condyle. The reason I know this is the medial condyle because we can see the adductor tubercle. So, with that being said, we need to determine which way we are rotated. And in this case, because the medial condyle is projected posterior to the lateral, we are internally rotated. So we need to externally rotate that leg until those condyles are perpendicular with the IR. And we need to direct the central ray cephalically 5 to 7 degrees to get a true lateral projection. So in our last practice analysis, we wanted to determine whether we have all our anatomic structures, which we do. We also want to determine there's a rotation in this lateral. And there is rotation because my condyles are not superimposed. First, we need to determine which condyle is which. So we're going to look for that adductor tubercle, which is right here. That indicates that that is the medial epicondyle, and it is positioned anterior to the lateral. So we're in external rotation. We need to bring those condyles back so that they are perpendicular with the IR. Next, inferiorly here, the medial epicondyle sits higher than the lateral. So we have some excessive angulation. We need to bring that angulation down to that 5 to 7 degrees to correct this image. This completes our image analysis of the knee. If you have any questions or concerns, please feel free to reach out to me at clinic or via email.